it does go through external quality review, and we have picked the initiation and engagement and treatment of alcohol and other drug use disorder measurement topic area as the SUD statewide PIP topic. So that was, if you didn't see your email, it's kind of, I put it in the email when we announced the agenda for this meeting. I do have your design summary. It's a resource document for you all as CCOs. And so that design summary will be going out shortly during this meeting. So I will submit that to your quality leads. Those quality leads are who are helping CCOs prepare your external quality review design validation form that due later this month. So that design summary resource is, again, just a resource to help you for your validation form. So I will submit that out to your quality leads by email here shortly. That is one thing that you've received. The other announcement for quality, because again, we moved the quality session topics to this morning. The other quality announcement is transformation quality strategy. You should have received an email about the peer learning that will happen in September. It's your transformation quality or TQS projects. We'll do from 1 to 3 in September, which are a whole host of projects, whether behavioral health, social determinants of health, access. You CCOs will pick your project, and then in the afternoon, we'll do affinity groups where you get to speak to your projects and learn from your other CCOs about some of those really cool projects. So that will happen in September from 1 to 3. Please look out for your email and then get back to us at OHA which projects you want to speak to, and then I will create some affinity groups and then publicize that out. What if you didn't get the email? You want to look to your OHA TQS leads, and then specifically I'll reach out to you who's asking, and I'll get you your contact. But each CCO has TQS leads that would have received that email. And then I'll publicize the QHOC TQS peer learning through the whole QHOC participants list, because again, those projects go across a whole host of learnings and quality and transformation. So we'll publicize that peer learning from 1 to 3 pretty broadly. Any questions about the SUD statewide PIP or the TQS learnings that will be coming out by email and or happening in September? Dr. Jeannie Savage or Doug Carr or anyone else have any announcements before we move into our first agenda topic?
Not for me, Lisa.
None.
Okay, let's go to the next slide, please. I am going to introduce this topic, and then I'm going to really honestly just hand it over and go off camera for a minute so I can actually send that SUD email. One of the conversations that we've had around MEP is that this tool, where it may have began in an actuarial financial side, has actually really transitioned into the quality, I'm just going to say the quality shops of CCOs. And I know that the quality performance improvement, which is the afternoon session of QHOC, the QPI session attendees really said, Lisa, can we talk about MEP and how we use it in our CCOs? And I said, yes, that's a really good conversation. The MEP team over in the finance actuarial teams have a work group, which is just sometimes comprised of different staff. And then there's the quality staff, and both are using this tool, and both are using it maybe slightly different, and maybe sometimes it's the same depending on each CCO. So the QPI attendee says, let's talk about MEP. Well, when we talked about that at the chair meeting, they said, we, the medical directors, also want to talk about MEP. So MEP is here in the morning session, so we can all learn about MEP and the usefulness and how we're going to use it within the CCOs for quality moving forward. So we've got some great people, and you know, I'm sure those are going to echo what Dave Elliott just put in the chat. So y'all are getting some props right now before I even introduce you. Shane, Shane is the consultant who works with us at OHA in regards to the MEP tool, and Will works for OHA in our actuarial team. So Shane is on camera, Will is on the phone. And so I'm going to turn it over to Shane, and Will is here just as a resource for any questions that might come up as well. Oh, Will's going to go on camera maybe. But Shane, I'll turn it over to you.
Oh, thanks. Thanks for having us here today. I think it's, for me personally, exciting to see a broader application of the tool. I'm just such a healthcare policy junkie that I love the idea of pulling in analytics wherever you can to help drive policy and improve outcomes. And I think this tool does a pretty good job of that, of providing kind of a unique perspective on how things are playing out in the delivery system. So it's great to be able to talk to you guys about it. I know many of you have seen the tool before. You can go ahead and go to the next slide. If you'd like. Thanks. I know many of you have seen the tool before, but some of you haven't, and this is a little bit of an introduction. So I'm going to go through kind of a general background of what the tool is and how it works, before we get to the conversation about how it's applied and how you might apply it differently in the future. So we'll spend probably around 20-25 minutes on some context, and then we'll transition into some discussion. But at any time, feel free to raise your hand if you have a question about where the specific content we're looking at, or type a question in chat, and I'll keep an eye out for those. So in terms of what we'll cover, the first up is what is the Care Improvement Opportunity Tool. If you go to the next slide. The tool is essentially a software and analytics that allow you to identify opportunity to reduce cost and improve outcomes. The tool itself, it's built off of a clinical foundation from Signify Health, and then Optimus did the software development and provides the user support. But collectively, the effort is called the Care Improvement Opportunity Tool. So hopefully it lives up to its name. If you could go to the next slide, please. So the tool itself, it leverages episode of care analysis. Episode of care analysis is essentially looking at groupings of clinically related sets of services that are generally associated with conditions or procedures, so diabetes, hypertension, asthma, or procedures such as knee replacement, CABG, that type of thing. This clinical overlay, so rather than just looking at all utilization equally, instead parsing it out into clinically related sets of services, it's particularly useful because it allows you to delineate between care that falls under the category of an adverse event and care that falls under the category of typical care. And that has a lot of utility in terms of providing insight, because those adverse events highlight where there's opportunity to either improve processes or close gaps in care, but it provides insight that can really help you inform your strategies for managing the delivery system. At the end of the day, the tool highlights variation in cost and outcomes. And again, it's really just geared at informing intervention strategies, which is how OHA has applied it in the MEP program. If you could go to the next slide, please. So we're going to run through just a quick overview here and talk about episode construction, adverse actionable event versus standard care or typical care, relationships around episodes, and episodes evaluated. And I think I have one example in this deck that we can look at quickly too. So next slide. Thank you. So generally speaking, the total process for episode of care analysis, it starts with episode construction. And it then goes, once the episodes are constructed, into a delineation between adverse actionable events, typical care, and then there's what's called an episode roll-up, which we'll talk about later, but it's essentially looking at relationships between episodes rather than looking at each episode in isolation. Next slide, please. So at its most basic level, episode construction relies on just a few core concepts. The first is what's called a trigger event. A trigger event is a claim in the data that suggests the presence of an episode. So for example, for any of the procedural episodes, it'll usually be something like the actual surgical intervention. So the actual knee replacement, hospital stay. For chronic disease, a trigger event, it actually looks for two. So a primary event that suggests the presence of a chronic disease. But because chronic disease identification is not a perfect science, it also looks for a confirming diagnosis somewhere else in the claims data. Once the presence of an episode has been triggered, the tool then creates a window around it. So there's a look back period and a look forward period. And the idea is to essentially what's happening on the bottom here, to take the total set of utilization and extract just the component that's clinically relevant for each episode. If you could go to the next slide, please. So once that clinically relevant set of care has been, of claims that represent care has been isolated, it's then delineated between adverse actionable events and typical care. So an adverse actionable event represents utilization that's potentially avoidable with the right upstream care. Examples of adverse actionable events include postoperative infections, admissions for high blood sugar. They generally are exacerbations of chronic disease or medical errors or potentially preventable errors such as the post-op infection. If you go to the next slide, please. Oh, I'm sorry, was there a question? Okay, maybe not. All right. This next slide here, it's just highlighting a tool that's available as part of the analysis, but you can see at the bottom, there's an example here. You have two different episode types. You have the chronic disease episode of osteoarthritis, and then you have knee replacement, which is a procedural episode. Clearly, there can be a relationship between the two. And so in the analysis, you may want to roll up the knee replacement into osteoarthritis and look at really a little bit more comprehensively the experience of that individual with osteoarthritis. We don't really get too heavily into this level of analysis for how it's used in Oregon, but I would just note that that is something that's available. Kind of the real core concept to take away is the construction of episode really focuses on identification of a specific set of clinical conditions or procedures. It pulls out what is clinically related to those based off of definitions that are developed by experts in the field in the treatment of those conditions. And then it bifurcates between potentially avoidable or adverse actionable events and standard care or typical care. And then I'll show you how you take that information and you turn it into what can be really powerful analytics here in just a little bit. If you could go to the next slide, please. So here, this may be pretty small on your screen, but we're looking at the list of procedures that are included in the tool and the list of chronic diseases that are included. I don't think these would generally surprise you. These do tend to be the types of procedures that have some of the higher volume as far as procedures go. And then additionally, the chronic diseases, these are the ones that definitely represent the biggest impact on state costs typically, and unambiguously, they always have significant amounts of adverse actionable events associated with them. So particularly for the Medicaid population, you also see that there's the maternity episodes, there's pregnancy and newborn, also under the procedural episode, the vaginal delivery and C-section. Those can be pretty impactful for the Medicaid population, given Medicaid covers a disproportionate percentage of births. But if you're interested, you can actually look at the underlying episode definitions at the link that's posted at the bottom. Again, that's from Signify Health, and you can see what's considered clinically relevant for building an episode. You can see some of the general parameters around it in terms of how many days before, how many days afterwards. And you can also see the list of procedures and diagnoses that are considered adverse actionable events. If you could go to the next slide, please. This is just a simple example of an episode. You can see that there's a trigger event. We're looking at a knee replacement episode. In this case, the inpatient admission signaled the presence of the knee replacement episode. It's pretty straightforward for procedural episodes. But as I mentioned before, once you have the trigger event that suggests the presence of an episode, the tool creates a window around it and pulls in all of the clinically relevant utilization in both a look back period and a look forward period. In this example, leading up to the inpatient knee replacement surgery, there were pre-op labs and imaging. Following the surgery, there was an admission for a post-op infection and additional professional visit for post-op follow-up care. Yeah, David, I see your comment. If that link is no longer valid, that means I've been recycling that slide for a little too long, and I'll make sure that we get you an updated link. So that's how the episode is constructed. Those were the clinically relevant services for this procedure, but you'll also note then that next important step, the delineation between typical care and adverse actionable events. The inpatient admission for a post-op infection that happened on July 14th was flagged as an AAE. That would have been done based off of the presence of a diagnosis for the post-op infection. So kind of a simple example just to show trigger events, creating the window around it, and then how some of the procedures and claims are flagged within it. Let me check and see what's next here. Yeah, so I'll pause there. Does anyone have any questions about the general concept of episode of care analysis? Where we're going next is to talk about why it's useful, and then we'll show you how it's actually applied in the MEP dashboards, and then we'll ultimately land on a conversation of how we might make it more useful for all of you.
Yeah, hi, this is Jeannie Savage. Just curious, Shane, is there any plan going forward to incorporate kind of like the next step, looking at when you do identify adverse outcomes, breaking that down in terms of race and ethnicity? Do we have adverse events that are happening more frequently in the populations that we have marginalized? How do you go forward looking at that?
We actually have a whole section that's talking about health equity as a potential future use case. But leading up to that, I'll show you how you can currently stratify the results based off of different population characteristics. So if we just put a pin in it, we're going to answer that one pretty robustly in just a few minutes here.
Great, thanks.
All right, well, seeing no other questions, why don't we keep rolling here? So let's talk about why just having isolated a clinically relevant set of utilization and then delineating between standard care and AAE can be useful. If you go to the next slide. So one key point that we'll start with here, we talk about taking the total set of utilization and only carving out the utilization that can be attached to a specific episode of care. What we're seeing with the current build of the tool is that you're actually capturing a little over 50% of the total utilization. So even though you're carving out services that are not really related to the specific episodes that I showed you earlier, you're still capturing a significant amount of your data. And with the clinical overlay and the way that you can stratify it is providing insight both on financial opportunity and improving care and outcomes in a way that you don't typically have access to. So it's not like some tools like waste calculators. There's so few dollars associated with it in the grand scheme of things. A different strategy is usually needed. I think that this is a great one. The other thing about it is that because it's impacting such broad swaths of dollars and with such granular information on what's happening, it can help the state support prioritization of policy. The claim level identification of AAEs allows you to slice and dice the data in just about any way you can think about it, because you can look at the impact on individuals, that allows you to look at the characteristics of individuals. And so just like the question from Jeannie there about health equity and marginalized populations, you can absolutely stratify the results to look at, well, are you seeing significantly more adverse actionable events for certain populations? And then to start to dig in at maybe working with communities to understand why that's happening and to craft interventions to improve health equity. In addition to being able to stratify based off of patient characteristics, the results, since they're mapped to the claim level, you can also incorporate geographic analysis. That can be really helpful for hot spotting where you may have areas where you have different types of issues that are unique to that geography. And being able to do that allows you to craft policy that's more strategic and ultimately more impactful as a result. You can look at analysis by different cohorts, so those with similar disease burden or characteristics, and you can focus on common complications. So for example, one of the CCOs is focused on an intervention around sepsis, because sepsis is a complication associated with many of the chronic diseases and some of the procedural episodes as well. And there are lots of dollars associated with it, but really that's tip of the iceberg. Any way that you can think about stratifying the data, since it's mapped to individuals, you can do it. Next slide, please. So quick overview, quick question here. So how precise is the geomapping? Currently, the geomapping is at the zip code level. That's the level of granularity that we have in the claims data that we receive. If there was a use case where we're actually doing this in one other state, but we're essentially taking member addresses, running those through a very precise mapping program, and you can actually look at travel distance to care and stuff like that. But that while you can do that, that's not done. What's currently in the tool at the most granular level is zip code. So how is this tool used today? We have the MEP program and some interactive dashboard analytics that support that and potentially serve other use cases for the CCOs as well. If you could go to the next slide. So for MEP, I am sure most of you are familiar with the program, so I'll keep it relatively brief here, but the idea is that CCOs use the analytics to identify opportunity, craft an intervention strategy to impact that opportunity, implement that strategy, and then report on it. And then it becomes an iterative cycle. Comment here, so from David, the member level data output from the tool doesn't include additional attribution data. Any CCO can crosswalk that into the outputs using data from 834 files easily enough. Yeah, thanks for that explanation. All right, and there's a handful of examples here of some of the strategies that were used through the MEP program. But if you could go to the next slide, and there's a broader overview here. So you can see some of the more specific proposals for 2022, or going into the next phase of the project. This is just a handful, just to illustrate that there's actually quite a bit of diversity in terms of the strategies that the CCOs are selecting. They ranging from actual member education, practice supports, quality metrics, to expanding access to medication-assisted treatment. It's pretty diverse, and I think that's great. What that means is that the CCOs are either aligning with the other different types of efforts they have to address their local community needs, or they're getting different types of insights from the dashboard, which is also good. So, if you could go to the next slide, please. So here we're going to show you the actual dashboard that the CCOs all have access to. I would just make a pitch that if you don't have access to this and you see things that could help with your quality strategy or provide insights on managing your population, we can work on getting access to the dashboard. Well, there's a process for that, but if you just connect with your current users, they can tell you how to do that. I don't think we have a slide in here with instructions, but like I said, if it sparks your interest, feel free to dive in and take a look at it. I think there's a lot of really powerful information in here. So if you go to the next slide, please. So what we're looking at, or what we were looking at, is just the overview of all of the different tabs. You can see them across the top here, although it's kind of small. But the very first tab that we have in the current version of the dashboard, it's essentially around filters. This just lets the user go in and change parameters so that all of the downstream analytics within the dashboard can be adjusted to reflect kind of the subset of what you're interested in looking at. The filters that are applied here, the episodes themselves apply different criteria, and this can allow you to ignore some of those criteria. So for example, there's an age filter. Some of the episodes, they'll identify the presence of an episode. However, based off of the age of the individual that had that episode, they would be excluded. Part of the reason that happens is that when you have individuals of a certain age for certain episodes, they're an outlier from a clinical perspective, and depending on what your specific use case is, you may not want to include outliers for any reason. But this is, again, it's a tool at this level to help you interact with the data in a more meaningful way via applying different filters. Next slide, please. So after the results are filtered, there you go. There is a summary slide. The summary slide says essentially how many dollars went into the tool and how many came out. So that's answering the question of what was a set of utilization that was fed in versus what subset of that utilization could be mapped to an episode. And then next it shows you, well, what are the top episodes based off of the amounts of dollars associated with those episodes. Here we're looking at the actual statewide totals, and you see that substance use disorder by no small margin is the highest total expenditure in terms of dollars going towards an episode. It's followed by all chronic diseases as they bear the greatest amount of cost, diabetes, hypertension, and asthma in that order. The next set down with the blue and red. So here's where you start to see the application of the delineation between an AAE and typical cost of care. Here, it doesn't always happen this way, but here it has in terms of the total amount of AAE dollars are actually aligned with your same order for total dollars. So what you're seeing specifically here is substance use disorder. For this data set, you have $673 million that are associated with the substance use disorder episode, and of that, $178 million are for AAEs. I just note that these dollar totals are based off of 3 years worth of data. So just keep that in mind. It's not an annual number, and we're looking at statewide totals. And these results do change depending on which region you're in, because the underlying health and the disease burden varies depending on which region you're in. Next slide, please. And Lisa put in chat how you can get in touch to get access to the dashboard. So feel free to do that if you're interested. This first view, we're still looking at really a summary level, but what we have here is the statewide broken out by counties. So when you're looking at your own dashboard, you're going to see data in multiple counties, even outside of your region, but they're based off of the member's address. And in some cases, you have a member address outside of your region. It could be because they've moved or for whatever reason, but so you may have one or two members that are driving what you're seeing. But again, the summary statistics, episode count, member count, the dollars, the bifurcated dollars, AAE and typical, and then top episodes based off of total cost and by total AAE. If you could go to the next slide, please. Here we're looking at a slightly different view. You can think of the dashboards as getting more and more granular. So we started out at the highest level, and now we're starting to drill down and look at the provider level. You can, at every dot on this rather messy scatter plot at the bottom, since it's statewide and we're looking at all episodes, you can see that there's a lot of little dots, but you can actually focus on an individual episode and see how providers compare on an average cost and an average AAE rate. There's different attribution. The Ccos can provide attribution. So you're looking at the total care related to that episode based off of their attributed primary care provider, or you can look at hospitals. You can also use various filtering on this to narrow down to what you're interested in looking at. But the key concept here is that you can start to look at variation at the provider level. If you could go to the next slide, please. Here, this is just getting a provider overview. In the provider overview, you could select an individual practice and you can see some of the similar statistics that we looked at previously. So the total dollars, the AAE dollars and whatnot. If you could go to the next slide, we'll keep going here. This, you start to see even more granularity. So this, you can actually get down to the member level. What I want to highlight here, just a handful of things, is that you could drill down and look at an individual member and see what their experience was across time. You can see the individual diagnosis codes and the associated dollars, again, bifurcated by typical and AAE. You could look at procedure codes. You could look at an individual member or set of members based off of the specific episode of interest. And then here that you can also start to filter based off of different characteristics. So you have the, you could look by attributed provider. You could stratify the results based off of age, based off of gender, category of aid. You could look at individual counties. You could focus on specific categories of service in your analysis. So this really does get to the point where you can start to mess around with some pretty granular statistics. This is where a lot of the heavy lifting happens in terms of trying to figure out what you're seeing in terms of what's driving AAEs, and so that you can start to drill down and craft strategies for intervention. Next slide, please. The episode subtype. So just this provides some statistics based off of a stratification for subtype. Subtype is just the concept of some episodes have meaningful delineation. So for example, with diabetes, you might have someone with type 1 or type 2 diabetes, and your statistics and utilization may be different between the different subtypes. Substance use disorder, for example, there's multiple different types of substance use disorder. This isn't currently filtered down to anything. I take it back. So it's filtered down to hip replacement. You can see there's quite a few different things in here. So if you could go to the next slide, please. So just a useful view for developing more intuition. The last, well, two more, I guess, but this is the last really meaty one. So this is on substance use disorder. There are some different data sharing constraints related to substance use disorder. And as a result, the level of aggregation is higher. However, we have had some requests to provide a little more granular detail, which we think we can do without running afoul of 42 CFR Part 2. So we'll be adding in some more granular stratifications. But here you can see you have a mapping of providers based off of average episode cost and fact percent. And then you can look at the actual episode subtypes based off of the ranking for AAE dollars. Here it looks like far and away the greatest costs are associated with alcohol abuse as opposed to others. Cocaine and amphetamines comes in second. There's a ranking based off of rendering provider. That does raise kind of a key point related to this analysis, which is when you're looking at a member's total spectrum of care that they receive for a condition, you're going to have multiple actors that contributed to that care. And we try to provide the resources to where you can focus on who's most likely to be the party that should be held accountable. So for example, for procedural episodes, having a hospital stratification, being able to assign to primary care medical home for chronic disease and whatnot. So just, be cautious. Rendering provider may not be the one that's responsible for getting upstream of that bad event that they help treat. So even though we've provided it here, just a grain of caution. You can also see, similar to some of the other views, procedure code breakout. And then on the heat map there, it's that I believe is a zip code level analysis that is showing the relative differences in AAE cost, and that should react to selections that you make down below. So if you wanted to look at rendering provider, AAE dollars, or even procedure. All right, next slide, please. Other views are useful for downloading data. We continue to update the dashboard. We've had some really good feedback recently, in particular, that I think we're going to be able to build out some good functionality, provide more granular data on SUD, for example. And then part of what we want to talk about today is what you would like to see and what would be useful to you on the quality side, because we can look at doing that as well. All right, if you could go to the next slide, please. There are just, I gave the lead in here. Folks are asking for stuff and we think we can accommodate. So let's talk about what that is. If you go to the next slide. So one thing that was raised is to consider adding additional data stratifications that are aligned with TQS. So that could be SPMI, long-term care utilizers, duals. The recommendation received was to work with the TQS team to create cohort definitions for populations of interest, so that when you're looking in the dashboard, you can stratify based off of those populations. Also, I've already mentioned more granular detail for substance use disorder. Next slide, please. Another application that OHA has led the charge on is to begin to incorporate some health equity analysis. We haven't built this in yet, but as I mentioned before, because we're mapping at the individual level, the results are going down to the claim level, which tie to individuals. You could absolutely add in all sorts of health equity statistics. The examples that you see here are from some work that we did in Pennsylvania. So we built this health equity analysis tool, the HEAT tool, and it essentially looks at population characteristics, population health statistics, and it overlays Medicaid statistics so that you can isolate areas that have issues with both. So you could look at where there is food insecurity and exacerbation of diabetes as an example of how that might be useful. Here, this particular view we're looking at, it's a combination of 3 indices: Medicaid data, population health, and a social determinant of health index. Next slide. This is just another example. I won't go through it due to time, but it's essentially looking at social determinants of health to provide kind of some context in terms of how things play out geographically. Next slide. Another example of some of the information that we pulled into the tool in Pennsylvania, but looking at redlining. Redlining was a policy that had a very significant impact on populations and communities that actually correlates with a massive impact on health. In particular, just kind of a startling statistic, but based off of redlining zones, you can see a difference in life expectancy of 20 years, which is mind-boggling. Next slide, please. So I probably spent too much time on that, apologies, but I think what you can see is that the analysis, key takeaways, it really ties back to a clinical basis, clinically relevant services. It creates this delineation between good and bad, or good and potentially bad. And then there's all sorts of stuff you can do from it downstream. And so this leads to the question of, based off of what you're seeing, what some of the capabilities are, what do you see as a potential opportunity for how we might augment the analysis to help you gain insights on the quality side? Or if you have good examples of what have you done to integrate the tool from a quality perspective that you found to be useful that you think your peers could learn from, that would be great too.
We've got a question already teed up, and this is where it's kind of the open dialogue. So if you want to go on camera or start putting questions in the chat or raising your hand. What is the time delay between claim submission and information in the dashboard, and how often is the data refreshed? And then we'll kind of put the technical questions, and then I think we also want to hear kind of the strategic questions of how is it you all want to use the MEP in your quality and clinical programs in your CCO? So that's just, I know that's like the solving the world hunger kind of question, but that's really what I think Shane and I are looking for, and Dawn, as far as how you all want to use the MEP. And so you can put technical questions, and you can also put kind of those strategic questions into the space of this next dialogue. And Shane, do you have an answer to the how long the time delay is by chance?
Yeah, we have been using, for practical reasons, the managed care rate setting data because it's scrubbed and clean and uses the process once that way. Consequently, we're updating the data annually in August using the prior calendar year's data. And then we actually include 4 years to run the analysis, and then the dashboard contains 3 years. So the consequence of that is that it can have a significant lag, a maximum of, I guess, 20 months. And well, yeah, between that, there's different ways to parse that statement, but yeah, it can be as long as 20 months and as short as 8 in the most recent data set. We have talked about doing it on a more frequent cycle. I think that if there's a use case, there obviously would be a process to go through to, we don't have a second cycle for getting the data, cleaning it, and then running the analysis, and we'd have to build that in. Generally speaking, though, because we're looking at a unit of analysis that crosses time, it is useful to have sufficient run out for the most recent data period to make sure that you're capturing, for example, hospitalizations, which tend to have a longer claims lag. So I wouldn't recommend anything really shorter than 6 months.
Fine, you can talk. Yeah.
So it is a bit of a rear view mirror. It's what happened in the delivery system, what patterns have you seen, and then how do you change trajectory going forward. With the MEP projects, we do recommend having metrics that are a little more real-time that get at the type of things that you saw as a problem in the MEP dashboard.
And in the quality world, rear view mirror is known as the quality assessment. So the quality assessment, performance improvement. So you're doing a look back, quality assessment, rear view mirror, and then you're determining where you're going. That's the performance improvement part based upon your look back, your rear view mirror. What are people's thoughts on how and what, if you could, have your wish list? Not that there's that easy button. Still haven't found the easy button, everyone. If you had your wish list to what you could put in MEP, what would that be?
Lisa, what do you mean put in MEP?
Well, for instance, like some have said, well, Shane showed us, like, for instance, Pennsylvania, they went and did this whole, well, they did this like redlining, what was redlining, right?
And just a whole analysis around health equity. You can do similar things in Oregon if you're interested.
So their health equity analysis took their redlining districts, and that's how they defined their health equity analysis. We could do social, and they use social indices, which is a whole nother analysis. So if we were to approach our health equity analysis, we could determine how we define that. We could do food deserts. I'm making it up, honestly. So that's kind of what we're looking to you all. How and what, if we could take richness of data sets and combine them, what would that be? And we have Shane and be like, oh yeah, we've already done that. We did that in Pennsylvania, or we did this in North Carolina. We know what they have done. If you had your wish list, what would that be? I'm thinking food deserts potentially. Dawn's going on camera. She probably has a thought. David Elliott's put some thoughts in here. It could be in the health equity frame. It could be something like David's saying, member level. It could be, obviously, to Jeffrey taking fee for service and making sure they have access to the dashboards and things to that level. And Dawn's like, yes, please. I think that's the question. I'm going to go, Dawn, not to you. I'm going to give you second. I want to get Safina in. So let's go Safina, then Dawn, and then go from there. Safina, you got the floor.
Thanks. So I just want to clarify. I think I'm wrapping my brain around your question. So your question is about data sets and blending data sets, not specifically about MEP. And I asked that because when I think about MEP, and I know it seems like it's on a trajectory more towards quality, looking at costs, like it started so much from a financial cost perspective that I have hesitation to even venture to think about what you're suggesting, even though in concept, I love the idea of data sets of food deserts and health equity and stuff. But if we're thinking about it from this financial cost perspective linked to the PBR, I have a huge amount of concern about that. So I guess I'm still struggling with what the question is. The question about overall state level, CCO level, whatever, like data for quality improvement in general and population health improvement and addressing disparities and all the work that we're trying to do in general? Or is the question about MEP? Because I don't see them totally concordant unless we're like really shifting more to quality improvement. And then the other thing I'd say about MEP, I just want to put this concept out there, is like, I totally get that the data is retrospective and respect that, and that's fine, and it identifies opportunities, and then we choose episodes and do projects and whatever. And knowing that the data is retrospective, what we choose to do may or may not like fully 100% impact it, because it's not, it potentially might not be the exact same population. So I just want to put that concept out there. Like when you do quality improvement like that based on retrospective things, it's like conceptual, and again, I then have some concerns about it being linked to rates and stuff like that. So I think I have an issue with the rate linkage with all of this. So
yeah, I think this originated, and maybe Will, you could provide more context too, but I feel like what I heard is that the CCOs had been asking for tools from the state to better understand the populations, and that this was introduced through the actuarial side and tied to rates. But the reality is you have a tool at your disposal that is slicing and dicing populations in a way that provides insight into, even if you set the money piece aside, you're seeing where there's exacerbations of different conditions and where there's potential failures in delivery system that is useful. So the question I think is broader, is because the OHA has already made an investment to provide this tool to you, how do we maximize its utility? And that requires thinking beyond MEP.
Shane, this is Will. I think you've summarized those considerations very well. And some of the history is before my time, but I think that's the general gist of it. And I would second that. I think a key question here is, perhaps repeating, but we've got this very, very powerful tool here, that can help us identify patterns of care that aren't working as well as they could, and potentially come up with ways to improve on that. The question, I think, though, is how do we use this tool strategically? And we've had a process to use it over the past 3 years, let's say 2020 through 2022, that involves interventions. And yes, as noted, it is Ccos participation in these interventions and reporting upon them is linked to rates. It's essentially it's kind of like a process measure. Ccos have to do the work. We're not grading the outcome. We're grading that the work is done, and that can potentially change in the future. That's something that OHA is discussing internally. But we'd like your feedback. What can we do strategically with this tool to maximize its power and its applicability?
I'd like to follow that up with an acknowledgement of Safina's observation about a shift in this conversation and potentially in prior conversations from the actuarial and financial perspective door through which this tool entered the system, and shifting from that as the primary goal for this tool to the health equity goals and outcomes that have come into focus as the center and core of our work. And of course, as a clinician, and as so many of you are clinicians, that's my bias anyway, that's what we're here to do. And I know the cost containment and goals and all of those things are also critical elements essentially to do the most with what we have. But the shift is one that we're discussing explicitly internally as well, and the fact that Will comes as the primary lead on this from the OHA angle, and Shane and Will have been working together for a long time, is under discussion as we are determining quality and clinical partnership in taking more of a leadership position or participation in how to best use this tool. Not that it needs to be focused on the finances, but really on the clinical and community level equity and health outcomes that we are here to support.
Jeannie, to your question, I think you should, we're going to pin that one for when Kwaku and Marjorie come about the race and ethnicity, the real D update, which is at 11:30. So
okay, so that just answers then that the data that you're using, Shane, and your team is a data that you already have from the OHA. So there's not any new data that you may have access to, is what you're saying, Lisa.
No, Shane doesn't magically have any better data, unfortunately.
Right. Yeah, exactly. Okay, thank you.
One caveat is, and we use this strategy in Pennsylvania actually, but there's just a wealth of data at the census tract level, which is fairly granular. And you could do a kind of little mini population analysis based off of census tract publicly available data. But to Lisa's point, we for sure do not have member level better data than OHA would, because they're our source of data.
Yeah, the data that has been used that may be, quote, better than the 834s is when you're taking it from like a whole host of different data sets that are outside of the 834s, and that is not what Shane has. Let's put it that way. But I do see some concrete, David Elliott has put some other insights on what MEP could be used. And I think Will is talking about, again, the disassociation from the rates and all that conversation. So I think as you have seen Shane provide some context and a little bit more detail about where MEP, the tool, is at, Dawn and I are looking to met the tool in your quality and clinical programs. What enhancements in the tool can be used or can be suggested so that we can advise Shane, wonderful Shane, on, hey, Shane, can the tool do this? To David's point, can you export member level data? Can we implement a fee for service, member enrollment file for good old Jeff and Ray and our fee for service team? Those are the kinds of concrete kind of suggestions that we're looking for. And then we can have kind of that strategic conversations on the finance side of all this at a different dialogue. So MEP tool, clinical quality, how you use it in your programs, what changes you want in the tool, send those to Dawn and I. And then MEP finance, that's a different combo. We're kind of, I think what I'm hearing for Safina, it's probably better to split those kind of combos. Any last minute questions for Shane or thoughts? And yes, Safina, I'll put that maybe in the QHOC follow-up email. Dawn and I can work on that, and then you guys can we'll work on those questions and then get those in the QHOC follow-up, and then you can route those to the appropriate staff. That sounds good?
Appreciate your engagement, Safina, and others. It's
an interesting conversation.
Yeah.
Great. Thank you, Shane, for just giving everyone a good brush, and look for that email so then you guys can loop back with your respective teams and give us those questions before we all forget all the richness that Shane just taught us. Let's, to Lindsay's point, will MEP be one of the required comments? That's exactly the very conversation we're having, Lindsay. So that will be probably one of my sub bullets of the questions I'm putting out to your teams. I'm going to turn it over to Ariel to kind of give you a quick HERC update, but she didn't say she needed a lot of time anyway. So you are on the floor, Ariel.
Good morning, everyone. I am Ariel Smith. I'm the medical director of the Health Evidence Review Commission. I just wanted to do some quick updates. We always have COVID codes, but now we've actually expanded them to public health importance codes. So there's a couple new codes for monkeypox. One is for the Jynneos monkeypox vaccine, which is specific. It's a 90611 that was opened, I believe, a few weeks ago. So you should have that open. There's another one for the ACAM 2000 vaccine, which is actually a smallpox vaccine, but the CDC thinks it will have action against monkeypox. So that would be 90622. So both those codes should be open. The vaccine currently is being provided by the federal government for free, but you are responsible for the administration costs, if any. And then they added a new diagnostic test that's specific for monkeypox, which is CPT 87593. So these codes are all open and should be opened by all your CCOs. Next slide, please. And there were no COVID codes, actually. I guess they were too busy with the monkeypox. So since our last meeting, the Behavioral Health Advisory Committee met at the end of June. They went through the ICD-10 codes that were related to behavioral health and substance abuse. They discussed conduct disorder, and their suggestion for the HERC is to move conduct disorder and intermittent explosive disorder to a covered area of the prioritized list. And this was sort of a request by multiple players, multiple stakeholders within state government, including the Oregon Youth Authority and foster care, et cetera, that these kids are getting care for conduct disorder when they're in Oregon Youth Authority custody, but then there's a lapse of care if they leave or they're released. So these would be allowing them to continue treatment or to allow treatment to help kids stay in their family and rather than going to foster care. So that will go to the HERC next week at our meeting to discuss further. Drug-induced movement disorders, this is just kind of a housekeeping code. These would be like dyskinesias from different therapies for severe mental illness. We also discussed insomnia, and the recommendation of BHAP is to add insomnia to a covered line with a new guideline. That new guideline would require that the patient either be in some type of cognitive behavioral therapy or have been in it in the last year and it wasn't effective before they get medications. And this is because of concerns that the evidence is really for cognitive behavioral therapy. Medications have evidence that they work in the short term, but there's evidence of harm in the long term. And then there's another carve out in the proposed guideline for people who have other mental health diagnoses and are receiving other psychotropic medications, might be eligible for long-term medications, as well as those people who are on CPAP. And that's just because of their increased risk of having sleep issues with those conditions. BHAP will meet again on September 7th. They requested that staff review our current lack of coverage for many personality disorders and possibly move those. And then there's another request that came from part of OHA about coverage for residential treatment for severe anxiety. That currently is not a condition that's paired with residential treatment, but might be a reasonable pairing. Next slide. So this is the specific guideline I just went through about insomnia, just for your reference. This is not a final guideline. This hasn't gone to VBBS or HERC yet, but this is what the BHAP folks are recommending. Next slide. So our next HERC meeting is next week, Thursday. As usual, you are all invited. It's a public meeting. You can just register on our site as a guest if you want to come and listen in. If you have anything that you want to speak about that's on our agenda, please sign up. Thank you, Daphne. It's this week, Thursday. I getting back from vacation in my head is, I don't know what day it is. But yes, you're welcome to, if you have any testimony on any topic that you wish to give, you're welcome to sign up to testify. Please do that as soon as possible. And if you just want to sign up to attend, please, you're more than welcome to come. The agenda and materials are on our website, and you should have the agenda in your packet. So if you have any topics that you want have any questions about, or you want any information from me, I'm happy to address that. Next slide. So that's the meeting on this Thursday. Our next scheduled meeting is the first week in October. We have a couple of issues already on that agenda. We're working on a policy for how to use quality adjusted life years, so we'll discuss that. We're bringing back a statement of intent for public health emergencies that we had discussed a few years ago before COVID, that the legislature passed a requirement for private insurance to cover certain things for public health emergencies, and we're going to bring that back to try to mirror it for the OHP population. I'm working with a couple podiatrists on some foot deformity issues. Hopefully that will be ready for October. Hydroseals, we cover these for people up to age 21. We've had some concerns that this is basically a form of hernia. We now cover hernias for people over 21, and so consider coverage for adult hydroseals, which hopefully would be pretty rare. These are usually treated in childhood. Autologous Chandracide implantation, which is a knee procedure. CPAP titration, I'm working with a sleep specialist to find to sort of fine tune our guidelines for when repeat sleep studies might be indicated. For example, if someone has lost substantial weight or had surgery for sleep apnea or something, those might be indications. So that hopefully will be available in October. And we're also planning to talk about human growth hormone treatments for people with Prader-Willi syndrome who have closed growth plates. So those are the things I know of so far. Please send issues and items that come up in your CCOs or in case reviews, and we're happy as always to take on any topics that you bring up. Next slide. Oh, yep. Just our oral health advisory meeting is also going to be in early October. They're going to look at the CDT codes, some expanded indications for dental implant removal, and review labial frenectomy. We currently cover the lingual, the tongue frenectomy, and this would be more the lip frenectomy. So if you have any interest in any of those, please let us know. Next slide, please. EBGS, our evidence-based guidelines subcommittee, will be meeting on September 8th and talking about bariatric surgery procedures. Again, you are welcome to attend this if you so desire. It's a virtual meeting, and you're welcome to sign up for that. Next slide, please. And then anything else for EBGS, any topics, these would be things that you want a more in-depth evidence review. We are very happy to get any input from any of you all. Next slide, please. So again, if you missed us last meeting, we are changing, or actually our group email has already changed to herc.info@oha.oregon.gov. So please try to not use our old email for the herc.info. I believe it's still getting through, but there's a grace period that's ending. So please use this new one. Currently, our state emails are continuing to be the DHS-OHA state.or.us. But these will also likely be changing to the new domain. So just keep that in mind, and we will update you when they do start that transition. Any questions, input, anything else for me?
Wait, go back and show the email again, please. Thank you.
And there'll be some time for when things will automatically get forwarded, and then at some point they'll just, you'll get a kickback saying, oh, it didn't go. So for at the moment, the old one still gets forwarded, but at some point you'll get a message saying did not go. But
Lisa,
yes, please do record the new ones.
Hi, Lisa, this is Dana with Willamette. Can you hear me?
Hi, Dana.
Hi. So does the prefix part of your name, like your actual name, change as well, or is that all staying the same and it's just the ending that's changing?
It's just everything after the @ symbol.
Yeah. Okay. Great. Thank you.
And right now it's just the ones that have a generic email box, and then at some point I've been told everything will change. We just don't know when it's the individual, like Lisa T. Bowie. I haven't changed yet. It's just every generic email box has changed. So right now the HERC email box has changed. It's the ones below the Ariel Smith, Amy Cantor, and Jason Gingrich haven't changed yet, but they will at some point, and we'll let everybody know when they do.
And there'll be several months, I'm sure, grace period after it changes for you all to catch up.
You'll be able to find us. Thanks, Ariel.
Thank you, guys.
You have no questions in the chat string.
Okay,
next
I'll
slide,
stay
please,
on
Michelle.
just in case there's any questions.
The COVID update. Dr. Paul Cieslak is going to give the COVID update. Thank you very much for joining Dr. Paul Cieslak. He's our public health in the public health division. He's also one of our epidemiologists. You can go ahead and go off mute, and you should have the floor.
Yes, thanks very much. I have to say that with the amount of COVID that's out there, and with home tests being used increasingly, and we don't reliably get the results of home tests, I no longer put a lot of stock in the actual case counts. So my main way of tracking COVID-19 at this point is looking at how many COVID positive patients are in hospital at any given time. I think it's a more reliable indicator because it's a really good bet that anybody with respiratory symptoms who's admitted to hospital is going to get a COVID test. And so the situation is like this. Our very peak date of COVID positive patients in hospital was at the peak of the Delta wave on September 1st of 2021, with 1,178 COVID positive patients in hospitals throughout the state of Oregon. A secondary peak came with the first Omicron surge on January 27th, with 1,130 in hospital. And so that's just sort of background to let you know how bad it can get. COVID surged again, in the summer with the BA4 and BA5 variants. And it looks like the peak of that summertime surge was on July 17th with 464 COVID patients in hospital. So, little more than a third, 35 or 40% of what those peaks were, and that was our surge. So thankfully, a lot less than previously. Since that peak on July 17th, we've had a bumpy decline in case counts and in hospital. And this morning, the number is 340. So hospitals are reporting 340 COVID positive patients. So that's down about 27% from the July 17th peak about 3 weeks ago. But it is still about 3.9 times the nadir that we had was on April 17th. So on Easter Day, we had the lowest count of the year at 88 COVID positive patients in hospital, and we would like to trend down more toward that number. I want to say also, though, that despite the fact that the COVID patients in hospitals have been declining, hospitals still remain quite stressed, with a combination of COVID positive patients and patients presenting for other illnesses, and what has become a chronic difficulty in discharging patients who need to go to long-term care facilities. So on any given day, there's about 500 patients sitting in Oregon hospitals for lack of a long-term care facility bed. So their stress is not over. Our projections come from Dr. Peter Graven, who has developed a model and perfected it over the last couple of years up at OHSU, and he's been pretty prescient in predicting peaks and valleys of COVID. And he predicts continuing decline for about another month, and then rising case counts beginning in mid-September based on waning immunity. So unfortunately, we're finding that the immunity that you get either from COVID vaccination and its boosters or from having been infected by COVID wanes fairly rapidly compared to some other diseases. And so, the population of people who are susceptible will continue to rise, and I guess, or begin to rise, I should say, in mid-December. I'm sorry, mid-September, and rise after that, according to his prognostications. As far as vaccinations go, we're not delivering a lot of vaccines, about 4,000 doses a day in the state. 3.2 million Oregonians, that's about 76% of all Oregonians have had at least one dose. 2.9 million, or 69%, have completed a primary series of vaccines, and about 40%, 1.7 million, have received a booster dose of vaccine. So we're continuing to recommend that people get all the immunity that they can get, all of the vaccines that are recommended for them, whether it be just the one series or whether it be one or two boosters. Get everything that's recommended for you, because we are expecting COVID hospitalization numbers once again to begin increasing. And if you're at particularly high risk, make a plan with your physician to quickly get tested and get a prescription for Paxlovid to try to keep you out of the hospital. One other thing I'll mention that I do track as I think a reasonably reliable indicator are people coming in for testing and what percentage of them have tested positive. And in our most recent biweekly report, which was through July 24th, the test positivity over that 2-week period was 14.2%. So a pretty high rate of positivity. On August 4th, the positivity rate was down to 11.8%. So the test positivity is tracking with the numbers of patients in hospital, and it does seem to indicate declining rates of disease, or at least severe disease. But I do think that despite the numbers of patients in hospital being relatively low compared to other places, I think COVID-19 continues to basically rage throughout Oregon and to spread to anybody who doesn't have immunity or to whose immunity has waned. There's a lot of it out there still. And that's all I have to say.
Great. Are there any questions?
Lisa, I have a question. This is Dana with Willamette. Are there are the boosters that are out now being modified to meet the variants, or is that too soon to do that?
Too soon. The boosters that are available are still using the ancestral strain. As you probably are aware, sounds like you're aware, on June 28th, the FDA's advisory committee recommended that an Omicron variant be put in the next vaccine, and those have been undergoing trials, but they're not yet authorized or approved for use by FDA. So we're kind of awaiting that and expecting that maybe, you know, if I could just hazard a guess, you know, maybe late September.
Thank you.
Thank you. Any other questions?
I want to acknowledge the role. Thank you, Dr. Paul. I want to acknowledge the role that the Ccos play and have been playing in providing support to OHP members and fee-for-service to KEPRO in providing support to get access to testing, vaccines, sending vaccines out to individuals who are unable to leave their homes, for example. So thank you for the innovation that you all have demonstrated in providing that proactive care to those most likely to have poor outcomes or severe disease as a result of COVID. And for staying on top of this, it's obviously developing into its next chapters and is not going to go away. We're just going to have to build this understanding into our practice over the course of time. So thank you. Thanks, Paul.
Thank you, Paul. Let's go ahead and go to the next slide. We'll be going on break, and then let's just have at least a good stretch break. Come back at 11:30 for the Real D conversation. So we'll see you at 11:30. Sorry, we ate a little bit into your break time.
I can't hear you, Lisa.
Oh, is our live captioning ready and set up, Marjorie? And okay, go ahead, Dawn. We are good to go.
Thank you, Lisa, and thank you to the Division of Equity and Inclusion staff who are joining us today. I am super excited and always a little nervous when I see the Real D content in a presentation because there's always something new. Doctors Kweku Wilson and Dr. Marjorie McGee are joining us today to bring us up to speed on the efforts to really understand how race, ethnicity, language, and disability data updates can inform our work. And I think we need to buckle up. We are going to see and learn about things that we are not prepared for, that are going to be difficult to understand and respond to, but we are going to have to figure out how to respond and commit in ways that are both new and long overdue. And I appreciate Marjorie and Kweku. I appreciate both of your work to this date and looking ahead, and partnership from everybody in figuring out how best to both collect and analyze and then use appropriately this data to inform the kinds of work that will give us the outcomes and equity that we seek as our 2030 goal. So thank you for joining us this morning, Doctors Wilson and McGee.
Thank you for having us. I'm Marjorie McGee, as noted, the director of the Real D and Surgery Unit, and Dr. Wilson is the data analytic manager for our unit. I thought we'd just keep this pretty high level and short and give you some really quick updates and maybe save some time for questions as long as there's time. The first thing to know is that we've done a lot of work to make this, to take our one data, the data from the one system, the eligibility system, and cleaning it. That the data that CCOs get now comes through a couple of processes, you know, from the one to MMIS, and then MMIS to the transaction files, enrollment transaction files. And as you all know, the WRD data in those files are challenging to work with lots of missingness. And this, in some sense, makes sense because the data systems that collect WRD from the one was not intended, it's an administrative data system. And we usually only ask WRD and so WRD questions and gender identity at the time of initial enrollment application. So if someone's on an automatic renewal, we won't be able to ask unless they somehow do a whole full application, which is very unlikely. So if there were no changes to be made in the application substantial, then we would not know. So that's why there's a lot of gaps in the data. It's because of, and many of our folks were enrolled before we had WRD. So, however, when you clean the data, when I clean the data and take all the one data and I clean it and use some methods, imputation and using data that was on an early line and flowing it down to a later line and so on, we can dramatically reduce the missingness. And so instead of 40–50% missing race ethnicity, it comes down to 20%. And then when we go through adding other data, it's even less. So the good news, doing that, it takes a lot of work, by the way. It takes an enormous time, computational power, syntax, pages of syntax, and it takes a lot of time. The good news is that we are working with Deloitte to automate that process so that by December, we should have what we call an initial repository that will have both COVID, WRD, and surgery data for people who coming at it with COVID testing encounters, and also from the one system. And using that data together to fill out the gaps, the missingness. And we'll test that in December. And what I'm hoping you all will be excited about, along with us, is that between January and June next year, the CCOs will be able to access a flat file of the clean WRD and surgery data, gender identity data. So, you know how CCOs are currently getting a flat file for vaccination data? It would be that same sort of thing for WRD and gender identity. And then in a next biennium, a more cloud-based interactive data system. So instead of trying to work through the enrollment transaction file to get WRD and surgery, you can get clean, streamlined data from the flat file. So that's the big news I wanted to share today with you all. We're working in earnest. The Deloitte folks are doing SQL coding and cleaning, automating the cleaning process right now. And we meet weekly with our friends. We've been able to leverage COVID dollars, FEMA dollars, for much of this work. So we're piggybacking on the work that our friends in the crew have been doing, and then adding in the one data to that. We won't know in the repository if the person had a COVID test or if they're one data. We won't know that in the repository. But what will happen is we'll link it back into the MMIS folks. We'll link it back into the folks, and the COVID folks will link it back to their folks, so we can keep those confidential. Any questions?
Thanks, Marjorie. Let's see if there's, again, a reminder to use your reactions, raise your hand button, and or put it in the chat. One question did come up, Marjorie, earlier in our conversation. Someone talked about the 834, and I'm not sure if that's the flat file you're talking about.
Kind of.
Yeah, because there's so many files and data.
Right.
So that 834 enrollment file and that data set, and is that the data set that you're talking about that your team is working on as far as improving? And I know that's just kind of a loaded question. And then there's one more question that just got put in. So I'll let you answer that first one.
Yeah. So the 834 is for a specific purpose. It's very specific. Someone just called me. I had to turn off my phone. The 834 is a specific purpose with HIPAA compliant fields and so on and so forth. We're proposing that instead of using the 834 to get the READ and SOGI data, you would use the flat file to get it. It's very difficult to get clean READ and SOGI data into the 834 in a way that is best. It's more like a raw data dump that comes out of the one system. In the flat file, it would be clean with calculated variables. So instead of having 18 data points for disability, for example, 9 disability questions and 9 acquired, you get calculated variables that is a composite variable, probably several of all of that. It makes it easier then to use, because then you're not trying to, oh my Lord, what do I do with all this information? You can go right into using the data for analysis on your own population. So we're keeping them very separate. You'll probably still get READ and SOGI days with 834. That's out of my lane. I cannot speak to that. But the flat file is different.
Okay, so the flat file that you're working on is different than the 834 files that the CCOs receive. So as far as the 834 file improvement of real or race and ethnicity data within the 834, that's outside of your scope.
It's not even a good, I would not even say it's a good thing to work on. There's so many limitations on the 834 that it's not the best way to get the READ and SOGI data.
Now,
you wouldn't get clean data. You wouldn't get clean data.
That's the CCO's argument, which is who's on the phone. They want real good. Well, I'm going to speak on behalf of CCOs here, and y'all can, raise your hands or clap or say thumbs down. But the CCOs have expressed that they want good race and ethnicity data, and they're clapping. Thank you, Dave. And what they're saying is they don't have good race and ethnicity data. In fact, they said 60% is unknown in the 834 file. So they concur with your statement there, Marjorie. So where do they get good race and ethnicity data is on their members, is their question.
And that's the flat file that I'm talking about that we're gonna
That's the
have.
flat file that you're going to
It's a
potentially
completely different structure. It's not the 34. So, and it's a flat file for this biennium. So in between January and June, Gainwell will be building that flat file from the repository that we're working on right now. And then the plan is we put in a policy option package. The plan
Okay.
is to build a interactive cloud-based system where CCOs can go right in and grab VOD SOGI from for their members at any point. So that would be in the next biennium. But for now, it would be similar to the vaccination file. It's a flat file that Gainwell developed for CCOs. Be something similar to that for VOD and gender identity. And that would be much more superior than trying to deal with the 834 enrollment transaction file. Right?
Okay.
Trying to don't do that. It's too messy. You're paying a lot of money to do SQL coding and get it all cleaned up so that you don't have to do that.
Okay, so I think we learned a couple things. Number one, 834, messy, don't do it. And
Not
we
for
were at
VOD and
concrete-
SOGI.
Not for real gene SOGI, at least for that. There is a question out there that we haven't asked you yet, Margie or Kwaku. Will OHA ever accept real D and SOGI data provided by CCOs and their PCPs, whether that be in the flat file or in what we are saying is the not good 834s? Do you know for either one of those data repository sources, does that question hold true for either one of those that you're aware of?
Well, okay, so let's talk about the House Bill 3159 registry. When we put in the policy option package to build that, and when that is funded, we will be building a registry that for which providers and insurers and CCOs will be required to send VOD and SOGI data for their members and patients once a year.
Mm-hmm.
So when that system is set up, then we can receive the data from CCOs. And we can,
Okay.
yeah, and then it can also get cleaned and then go into the cloud-based interactive data
file.
linkage. Yeah. Now,
I gotcha.
by that time, we should not have flat file. It will. We're talking in the 25, 27 biennium, likely before we have the House Bill 3159 registry, functional. It's going to take time to build it.
Okay. Another question's come up, and then we might, but this I think hopefully has been helpful to CCOs because I think we've answered some pretty foundational questions. Question, is this a recommendation that CCOs stop using the real D data that is in those 834 files, or should we continue to muddle through what we have, since that's what we have, until we get this new flat file? So, there's that $1 million question there, Marjorie and Kwaku. When's that flat file coming?
Yeah, so the repository should be completed by December. We can ask Steve Westberg and his team about the flat file. But what I know is sometime between January and June, probably March, or I can't imagine it'll be January, February, because Gainwell needs to build it. But maybe we could be surprised and it'll come sooner, but not before January. So what do you do in the meantime? Yeah. If you, why don't Lisa, let me get check in with Stephen Westberg and see about those timelines for the flat file and see if there's a little bit more precise.
Yeah, and I think, okay, and there's a much longer comment, which I think I'm going to put my CCO operations hat, not that I've worked for a CCO, but David Elliott brings a point of how the CCOs are operating with their 834 files, which is they're basically enrollment files. It's my understanding is, can someone give me a thumbs up or a clap or something if I'm right about what those 834 files are? But basically they built their systems, i.e. their IT systems on those 834 files. So they get these 834 files every month, I think they're monthly, and they literally build their technology systems like off of those. Oh, daily, weekly is what David said. And they literally like build their technology around it. Like they upload them, they link them. And so they would have to unwind some technology, maybe. And that's why they're asking, like, do I stop using the real D part of the 834s or not? And or when these other flat files come out, and to what frequency those data files are coming out, that we're using real D SOGI data from a different file on a different frequency on a different data set, you know, when they've already integrated the 834s for a whole host of other parts of their operations. So what we do know is 834 is not a manageable, it's not a good data source for real D and SOGI. We've heard that from the real D SOGI managers of OEI. What we do know is that there's this flat file data repository work happening. We don't know the exact timing. Marjorie and Quaker are going to circle back with Steve Westenberg, who I know as well in the HSD world. We do know there's some conversation about the timing of that. And I'm sure Steve Westenberg knows about the whole 834 part. And there's some action item to figure out how those timings of frequency of that flat file, use of the flat file of real D SOGI, and how the 834 should still be used for a whole bunch of other things with CCO operations. So I will circle that as an action item and then bring it back to y'all.
Yeah,
and it most likely still should be not just in this meeting, but your CCO ops meeting. But it's what you do with that real D data, that's the QHOC conversation, which is why probably Don just went on camera. Oh no, go Don. I think Don had a question.
I just wanted to acknowledge the other question that in the chat that is about taking inputs from CCOs and PCPs and how that is expected to be built into any system anytime. Marjorie, could you please address that?
Oh, we did that one. That's when the implementation of House Bill 3159. I did ask Marjorie that one.
Sorry, I missed it. Thanks.
Yeah. Okay. Yeah, when we build a system where we can receive the data, then we'll take the data. But we put in a policy option package, we hopefully will get funded, and then we can build that system. It's a big system.
What I will also do with this, Marjorie and Quaco, is when I write my QHOC follow-up email, is I'll summarize this. I'll put some of those talking points into an email, pass it by both of you, including the action items, and preview it to you before I send it out, and then circle back and send it out to the, I don't know, 80 plus people on this call, or the email distribution.
Yeah, and I gave my email to Dave, everyone, but particularly David, but if there's anyone else who you've integrated 834 and now you're going, oh dear, oh no, this is gonna break it, email me, and so we can problem solve together. I'm really convinced that the 834 though is just not the right, it just doesn't work. Keep running into problems. It just keeps getting messed up.
That is very valuable information, Marjorie, and thank you. Any last minute questions before we move on to the next topic? Thank you, Kwaku and Marjorie. A host of rich information yet again, as we continue to move the much important work of getting the actual information so we can actually get to the quality improvement of this space. So thank you. I will wrap up some emails and action items like we talked, and I will talk to you all soon. Thank you.
Thank you.
Okay, looks like I'm presenting. So now I'm going to transition. Thanks for going on camera, Tom. I'm going to transition to quality strategy. So now I'm not your facilitator, now I'm your presenter. I'm going to present on the quality strategy of the Oregon Health Plan Medicaid. I presented in April along with Tom Wonderborough. Tom, if you'd like to introduce yourself. Star 6.
I think I did. Hi, my name is Tom Wonderborough. I use he, his pronouns. I'm a policy analyst in the Health Systems Division of the Oregon Health Authority, and I'm supporting Lisa on the quality strategy work.
Great. So I help from the strategy development part of this, and then the Medicaid office themselves within Veronica Guerrero's unit owns kind of the implementation of this. So just as a reminder, we're in 2022. We're in the specifically talking about the Qualified Direct Payment Program within the Medicaid office. We are not necessarily focusing on the 2022-2027 big 1115 waiver part of this. This is the overarching timeline that I brought to y'all back in April. As the negotiations are moving forward on the 1115 waiver related to health transformation, I'll then be coming back and talking more about the more significant quality strategy updates that will occur after that waiver. Next slide. QDP at a glance, the Qualified Direct Payment Program, are supplemental payments made to the Medicaid providers. They are based upon CMS approval. They actually have been approved, and the little asterisk shows that this is a slight change since I presented in April, so otherwise it's essentially the same. Rural hospitals get about approximately 146 million. DRG, diagnosis-related hospitals, get about 572. OHASU, the Public Academic Medical Center, gets 530. Ground Emergency Medical Transportation gets 19 million. And then sometime next year, we might be working on a preprint qualified direct payments related to behavioral health. So that's those last two were new to the since the April conversation. Next slide. Just as a reminder, so we were going, Tom and I have gone out to the Medicaid Advisory Committee, Health Equity Committee, looking for having this conversation with them as well in regards to public input on what the community and others have heard in as far as hospital care and the input we've heard so far. Cultural linguistic services, ensuring interpretation services at the time of care. That's one of the themes that we heard. And the other is access to care, ensuring access and quality to care in rural hospitals for all patient demographics. And then coordination of services with partners, DHS, primary care, transportation, Ccos. So when we basically ask the questions, how can hospital care be improved and what are you seeing in your communities? These are the kind of themes that we heard. Next slide. The conversation that we're having here today is with you all as CCOs. Again, this is the Quality Health Outcomes Committee. So we're talking about the quality strategy for hospital care, basically. Are there areas of focus in light of what you just heard from the other community inputs? Are there areas of focus in hospital care that align with your strategic directives? You are the Medicaid lands. This is the Medicaid Quality Committee. Are there anything else other than the three that you just heard? What are the current quality gaps in your hospital regions? As Tom and I are working with leadership and looking at OHA strategic objectives of where the agency is going, listening to the input we're hearing, we need to obviously start developing the goals and objectives in alignment with the CMS feedback that we've heard. Actually, it's not feedback, the CMS guidance that we've heard of what we need to do to our quality strategy. And so that's where Tom and I will be working in the coming weeks. And so we, at this meeting at QHOC, will continue to update on the quality strategy changes. And so this is the conversation for you all as far as providing that next input on any changes you are proposing or any feedback you want to provide. I will open it up for questions. Oh, and Safina's put comments in or put things in the chat. SUD treatment in the emergency chart. This would include the referral pathways after initiation of MOUD, which is similar to the third item on the previous slide of transitions of care. This would also include incorporating peers, which is in line with the traditional health work strategy. Thank you. So kind of that coordination of care beyond just the walls of the hospital. Thank you. This is exactly kind of like the inputs I need. So when I'm trying to develop goals, strategies, interventions, and measurement, that's kind of exactly the help I need. Thank you. Any other comments? And you can go off mic, raise your hand, or put it in the chat. And Safina, I know you represent Columbia Pacific. Is that just specific to the rural hospitals you're seeing kind of on the coastal region?
No, I think this is specific to
general?
most of the state.
Yeah.
I also chair the OHLC SUD subcommittee of the Oregon Health Leadership Council, which that's redundant, sorry, but and we're working on a toolkit for emergency department initiation of MOUD across the state and trying to get people to fill out a survey. And Oregon just is very behind, like needs to increase this aspect of the system of care for substance use disorder. So this is very broad and I think needs encouragement on behalf of hospital leadership, from the hospital leaderships to kind of move in this direction.
Great, thank you.
Yeah, and I agree with the collective platform too.
And or use okay. Thank you, Bhavesh. Thank you, David. Jeannie, did you have a comment? I can't hear you. *6. Can't hear you. Oh, she's going to chat. And anyone's thoughts on, especially in the rural areas, on the transportation? Obviously, well, and any confirmation that cultural linguistic services is a gap in hospital care, as I heard in the other committees. Basically, interpretation services. I know you all are working on it within CCOs, and so I'm assuming that includes in your hospital spaces as well. But that was a pretty strong message that I'd heard, that it still is a continued improvement area or an opportunity in hospital care.
Hey, Lisa, can you hear me now?
There you go, Ginny. Yep.
Oh, there we go. Yes, I would agree with your previous comment. And two, I'm curious, we did hear a little bit previously in one of our other conversations, and I think we're all aware of the difficulty in long-term care placement. A lot of patients are sitting in the hospital for a prolonged period of time. And I'm wondering how that might be considered in this discussion as well as improving quality in terms of placement, length of stay in hospitals. How do we incorporate that discussion here?
That was the conversation we had at the MAC, the Medicaid Advisory Committee, and they wanted to have the conversation of how the hospitals can essentially, they wanted to know the role the hospitals are coming to that table to assist in that community conversation of those, I don't know, say the bind of the placement and the transfers and the coordination and the care, not even like, if the long-term services is trying to get them out of there and the hospital needs to go there, and, the shifting, I guess you could say. And the MAC was really saying, can't the hospitals also assist in that help of that conversation? That was a conversation that the Department of Human Services, who also assists in obviously the quality and accountability of long-term services, they were on that MAC call, and we were actually supposed to have a follow-up to that MAC presentation. Unfortunately, it has been rescheduled a few times just due to family and competing schedules. And so I was just supposed to have it last Friday. So 2 of us were there, but unfortunately DHS was not there. So the MAC member and I talked, and I said, well, we really can't have this conversation without our DHS partners. And so we are continuing that conversation. What that looks like from a quality improvement and or measurement goal and objectives, we have not gotten there, but we have it on the list of things that we need to figure out from a coordination. Obviously, to the member, it does not matter that there's 2 different agencies. To the member and to the MAC member, it does not matter. So they want us to, quote, figure this out. They want us to define a goal and objective in some type of measurable way. How the hospitals and what the hospital's role is what the hospital's role, what the CCO's role, what the hospital, what the payer, what the state, what the policy, what all that has not been figured out, but that's clearly an objective. Whether that makes it in this particular round of quality strategy update, or whether that makes it into the next round, or whether that makes it into the OHA Medicaid quality strategy, or whether it makes it into the long-term services quality strategy, because there's 2, we don't know, but we're at the table. Let's just put it that way. And it's very clearly their one message. One priority.
Yeah, thanks for that. I appreciate it. I'll just say the hospitals we've been working with are very interested in being at the table and have done, have been great to work with. It's maybe the definition of roles needs to be clarified, but I also think that really looking at where the problem lies, and maybe a quality strategy in that long-term care might be more appropriate than here.
Great. Maybe Jeannie, I'll follow up with kind of some of the work. I know you and Maggie have been doing some work in that space, very obviously precipitated because of COVID and in those regions. But there could be some lessons from there, and whether it does fit in the Medicaid quality strategy, or like I said, in the long-term services, where's the right lever to put it in as far as an accountability structure. But the conversation came up for sure. Any other thoughts or items, please do direct to Tom or myself. CMS has been very directive in what we should be putting. You have given us some great additions with collective platform. Tom, obviously, if you wouldn't mind copying these 3 comments into here. And then we did get confirmation that obviously on the interpretation and then the coordination one that we heard from the MAC as well. Then we will continue to flesh out some goals and objectives as we move forward into detailing these out. You'll hear in September an update of goals and objectives that we'll be proposing for the first round of updates. Again, the quality strategy, just like your TQS, is a living document that gets updated every year. So will the state's one going forward. So this is not the first and or last of the conversation. So thank you as we continue to refine our own TQS version, basically. And you'll hear from me again in September on this with some type of updated SMART goal. I'm going to make them smart. I'm going to make them smarty, actually. I'm going to add some equity to it. Thank you. That's kind of, actually, yeah, thank you, Michelle. She's reading my head. We're going to be doing the goals, measurement, development, and then public input will be sometime in September. We'll probably just bring it right back here to QHOC, be going to the MAC. I'm going to get on the MAC schedule again. And then the QDP actual preprint application is due to CMS in October. So that's the actual schedule. Next slide. These are just the same links as far as if you want to see the current guidance, the actual guidance from CMS as far as thou shalt go do for the QDP preprint application or preprint letter. So there's that link as well. Next slide. It is now time to turn it over to Dr. Richard Lehmann for monkeypox. You all wanted to hear about monkeypox. Dr. Lehmann, I'm happy to turn it over to you. Thank you very much for joining very last minute.
Thank you, Lisa. Can you hear me?
We can. Technology is working.
I even use *6. I'm wonderful.
Nice
Great.
job.
Well, sure. So, hi, everyone. I'm Richard Lehmann. I'm a medical epidemiologist in the Acute and Communicable Disease Prevention section at the State Public Health Division. And for the next few minutes, we'll be talking about HMPXV or monkeypox. We'll talk about the epidemiology of the current outbreak, how it's affecting Oregon, and we'll also talk about how Ccos and public health can potentially work together in order to control this outbreak. So HMPXV is a double-stranded DNA orthopox virus, so the same genus as smallpox, but this definitely is not smallpox, as you'll learn in the next few minutes. It can present with fever, headache, and muscle aches as a prodrome, but during the current outbreak, while that's sort of the classic presentation, we have not always seen folks having a prodrome before the rash starts. In the current outbreak, rash is often the presenting symptom, and it's often in the genital and perianal areas. Typically, the rash starts with a flat patch that then proceeds to form a large, firm papule or more, one or more, and then can fill with fluid or pus, so vesicular or pustular presentation, which then typically scabs and falls off. Next slide. The incubation period, the time between exposure and onset of illness, when illness happens, is typically 7 to 14 days, can be up to 21 days. The communicable period is from symptom onset until rash has resolved, and typically that lasts for about 2 to 4 weeks. I will mention that some folks have pretty subtle presentations at times, and so may have a challenge recognizing that they have developed a rash until it becomes more pronounced. Next slide. So modes of transmission. In this current outbreak, the vast majority of cases have been from direct skin-to-skin contact with the active rash of a person who is actively ill with HMPXV. Less commonly, it is possible to have transmission from clothing or bedding that has been contaminated if people are not wearing gloves, for instance, when they're caring for a person who is actively infected. There is also some report in the past, although no cases have been reported during this outbreak, of the possibility of close ongoing prolonged contact, maybe within 6 feet for 3 or more hours, might also potentially lead to spread through heavy respiratory droplets. Next slide. So it's worth putting this in perspective. One person who has this infection actively, if you don't do anything to try to prevent spread, we would expect potentially 2 other people to get sick. So that's enough to propagate an outbreak. But if you compare this with, say, Omicron BA1, where one person, if you don't do anything, you would expect 8 additional cases, or measles, where you'd expect 12 to 18 additional cases. This is not an easy thing to catch. That said, it is transmissible. It is transmissible if anyone has the kind of close skin-to-skin contact with someone who has a rash. And so it's important that we do a coordinated response to get this under control and ultimately stop it. Next slide. So during the current outbreak, everyone from whom we have information nationally has had a rash. In some cases, lesions may be scattered, they may be diffuse, so it's not the confluent large pox that we have seen traditionally with this illness. Often, as I mentioned, these are present on the genitals or in the perianal area. The pain associated with lesions in the anus or the urethra or the mouth, of course, can be very severe. And some people have been hospitalized, less than 10% in the national outbreak. And hospitalization has typically been because of pain control and the need for that. So fever and muscle aches may be mild. They may or may not be present in this current outbreak. Often HMPXV infection is accompanied by by sexually transmitted infections, and most people are recovering at home. Next slide. So I think it's important to recognize what HMPXV is not. It is not a gay disease. It is not an African disease, despite the origin of the virus. And it is not really technically a sexually transmitted infection. That's not the only way you can get it. Although in this particular outbreak, up to this point, many of the cases have been associated with sexual activity. Next slide. So I got these slides to the organizer a while ago. So this is data from about a week ago. And as you can see, New York and California are leading the way in terms of numbers of cases. Oregon is at that point was at 70. We have a few more cases than that, and I'll be telling you a little bit more about that in a moment. Next slide. So again, it says 70 cases. We're actually over 80 cases at this point. We have also added single cases in 3 additional counties, although as you can see, the bulk of the cases have been in the Portland metro area and in the Eugene Springfield area down in Lane County. I just wanted to mention, looking at the right column there, most of the cases clearly have been among men. There have been some cases among non-binary folks, and there have been cases now in the last week among that are female. So I think that's worth noting. And I also wanted to note that many of the folks are men who have sex with men, gay or bisexual, but not exclusively. Next slide. So about 33% of the folks for whom we have information are folks living with HIV. There have been a small number of cases among folks who are unstably housed. I wanted to take a look at race and ethnicity, though, because as you'll see, there's a disproportionate representation among Latinx, Latino folks. And that is something that I think we need to address, and we need to make sure that we are doing effective outreach to that community. I think it also makes sense to begin outreach to the Black African American and Black African communities, although fortunately cases are fairly limited in that population at this point. But clearly, we've got some work to do in terms of making information available to folks, particularly folks who are men who have sex with men in the Latino, Latinx community. Next slide. So OHA is dealing with this outbreak and addressing it through communications, community engagement with various organizations that that have good connections and outreach with folks who are at higher risk, supporting testing, vaccination, and treatment. And we'll talk about a bit about those shortly. But I just wanted to mention the goals that we're attempting to realize during this. We want to make sure that people have the information and the tools they need to stay healthy. We want to make sure that we are supporting clinicians, local public health, and communities affected in this response. We want to prevent the further spread of HMPXV. We want to help limit the suffering from this, because this is not a fun thing to have. Yes, it may not be lethal, but it's no fun to have. And we want to help reduce fear and anxiety related to this infection. Next slide. So let's talk about a few ways in which we might be able to work together. What are some possible roles for Ccos? One is potentially encouraging providers to share harm reduction information with clients who are at increased risk. And there's a resource for you here that you might take a look at, and considering encouraging your providers to share this this information. Next slide. Also, if we can let folks know about testing, and we have materials on our website which can be shared with folks who are having orthopox testing to help them in the home situation, to isolate, to prevent spread to others, including members of their household. And these documents are available at www.oregon.gov/orthopox. Next slide. Also, just figuring out whether there are folks who are calling you, and figuring out whether folks who are calling you about vaccination would potentially actually be eligible under the current criteria. And I've provided a link here to the vaccine guidance. If we have time, we can certainly go over what the current criteria are. We certainly are focusing on making sure that we can vaccinate in post-exposure prophylaxis folks who have had direct high-risk contact with someone who is known to be infected with monkeypox. But we also have what we call post-exposure prophylaxis plus, or PEP plus, which can help in additional folks who are at higher risk. We can do our best to provide the best protection possible to as many people at high risk as possible, as quickly as possible. And if indeed you have someone who qualifies, they meet the criteria, then please refer them to the county health department where they live, and we can help arrange that. Next slide. So Dawn had asked me to kind of get through this in case folks had questions, and I'm glad to take any questions that folks have. Thank you.
Let me see if there's any questions in the chat.
Big thank you to Dr. Richard Lehmann. Thanks, Richard, for coming and for putting together those other resource slides in the slide deck, and for folks to be able to use. Safina asked for the slide deck for this separately with the links. Lisa, can we manage that?
Yeah, when I send out the QHOC post email, I will just fill out the monkeypox slides, and I'll put it as a separate attachment.
Okay, thank you, Lisa. Appreciate it.
Actually, Michelle, can you go ahead and just pull it out and just post it on the website? And then how do you want them file named instead of calling it monkeypox? Can someone give us that guidance, since we'll probably want to just name it however. We'll look to Dawn to give us the file naming convention, and we'll put it up on the website as well.
Okay, and we have been using HMPXV so as not to stigmatize, and actually it's not really typically the reservoir is not monkeys anyway. It's more likely rodents in the areas where it's endemic and enzootic.
Thank you, Dr. Lehmann. Okay, so Michelle, hopefully you heard that. It's in the chat as well, the little HMPXB, and
That'd
we'll
be
just
fine.
put that on the actual QHOC website as its own slide deck. It's obviously embedded in the larger slide deck, but then you all can just go to the QHOC slide deck, QHOC website, just to drop down that particular slide presentation to share amongst your provider networks. I'll also include it in the email when I send it out, but that will probably take more than just a few days. Any other questions or comments?
So there was a mention of prairie dogs, which was an interesting situation where someone brought in rodents from Ghana back in 2003. They were stored next to a bunch of prairie dogs that were on their way out as pets. And so a number of people who received ill prairie dogs ended up getting the infection from them. Interestingly enough, they did some pretty extensive testing just to make sure that this did not get into other animal populations, and there was no evidence that it did.
Okay, thank you very much. Next meeting is September 12th. As I mentioned, we'll have a TQS leads TQS peer learning in the afternoon. We have a learning collaborative slated for October, so we will have a full meeting in the morning. Please send any topics to Dr. Jeannie Savage and or Doug Carr for the clinical session in the morning. We'll have a P&T update as well. Otherwise, you all have a good rest of your summer, and we will see you all after Labor Day. Thank you very much. Anything else?
So,
Bye.
bye-bye.